The speaker is Dr. Teena Chopra. Could I have that introductory slide, please? Teena is a faculty in our group at Wayne State University in the Division of Infectious Diseases. And the topic that she has chosen to talk about is stewardship in a pandemic situation. So this is very timely. As you all know, what's been happening with SARS-CoV-2 that has turned the entire hospital care upside down. It's an incredible, I don't have to tell you, you probably are facing similar situation. Our rounding has changed, hospital occupancy has changed, emergency room has changed. So in the midst of all this, with the staggering volume that we have to deal with, we also have to practice stewardship. And as you all know, antimicrobials have skyrocketed in their use during the COVID times. And most of us realizing that secondary bacterial infections are uncommon, in spite of which the antimicrobial use has skyrocketed. I'm not sure why, I don't understand this. And the leading country for doing this in the entire world is India, where secondary antimicrobial use in the midst of COVID has skyrocketed, recognizing that the bacterial infections are not very frequent. However, so I think it's very appropriate to give us some advice on antimicrobial stewardship in the pandemic setting and how do we move forward. So Dr. Teena is a professor of medicine in the Division of Infectious Diseases and the Corporate Medical Director of Hospital Epidemiology, Infection Prevention and Stewardship at DMC, Wayne State University. Research interests include epidemiology of healthcare associated infections, infection prevention, stewardship, and immunization, published over 80 papers in various journals and book chapters, independently reviewed over 60 articles, special interest in immunization, studying epidemiology of C. difficile and multi-drug resistant organisms. She championed the mammoth task of leading COVID-19 pandemic for Wayne State University and the DMC. She serves on the Wayne State President's COVID Task Force and on the President's Public Health Committee. She's appeared on countless media and print interviews, including a variety of outlets. Teena, please take it away.
Thank you, Dr. Chandra, and thank you, Dr. Kavita, for having me. It's been wonderful to be part of this project, and I'm going to share my slides now. I hope you can see them. So before I start, I would, Marco did an amazing job of describing the stewardship program here in the US. I should also mention to you that this stewardship program is not equitable throughout the US. I do stewardship both at an academic tertiary care center and a law facility. We have a lot of alternate healthcare centers, which are like community hospitals here, and they don't have such advanced, robust stewardship programs. So it's important to realize, like you were mentioning, Dr. Kavita, the economic advantage and the economics around it are very important. And also the overall antibiotic use in the US will depend on not only the hospital antibiotic use, but also in the community and also in these alternate healthcare facilities. So it's important to remember that. And also with this, I would like to say that when we have pandemics and emergent situations like this pandemic, which no one has ever seen, what do we do with stewardship? What do we do with all these advanced programs we have in place? How do we follow them? How do we follow all these policies? Do we have any guidebook, or do we have any evidence, and do we have any knowledge about resuscitating stewardship during the time of pandemic? So that's what we're going to learn today. These are my disclosures. So let me start off, like Dr. Chandra pointed out, I mean, throughout the globe, antibiotic use was all over the place, The antibiotics like azithromycin were being, used like candy, and everybody was not aware of the fact that these patients Are they coming in with the bacterial infection on top of COVID? Their presentation was very, very unique. There was a concern for bacterial superinfection. It was very hard to distinguish COVID-19 from community-acquired pneumonia early on when we were seeing a surge of patients. And azithromycin use was much, much higher than expected, especially where we were seeing higher COVID numbers. So this was really, the azithromycin use was a marker for a reflection of its early promotion, throughout. And we saw it in our center as well. We saw it in whether we were advanced in terms of stewardship or we were behind. We saw a lot of antibiotic use. And when we have antibiotic use, we see more C. diff infections, right? We see the consequences, the parallel pandemic of antibiotic use in the form of, emergence of multi-drug resistant pathogens, more C. diff and COVID co-infections, which were also reported by our center. And we know that these multi-drug resistant infections are very, very difficult to treat, and they add on to the morbidity and mortality. So WHO actually came up with recommendations, wonderful recommendations for acute co-infections with bacteria. And they dogmatically recommended against using of antibiotic therapy or prophylaxis for patients with suspected or confirmed mild COVID-19. So this was like a guidebook, what WHO, of course, later on, but definitely a lesson learned for future pandemics and for other surges that we are seeing, for third and fourth surges. So these are some of those recommendations. They recommend antibiotics should not be prescribed for patients with suspected or confirmed moderate COVID-19 until there is clinical suspicion of bacterial infection. For mild, not at all. But for moderate, they said use empiric antibiotics to treat likely pathogens based on clinical judgment. So code blue of stewardship, resuscitating stewardship during these pandemics means basically you use clinical judgment. You want to use some objective criteria like CT scans. Is the CT scan looking like COVID? We all have seen so much of COVID now that we know what to look for in the CT scan. Is this a infiltrate that could be caused by a bacterial pneumonia, or is this a viral infiltrate? So using your clinical acumen is going to be extremely, extremely critical during these times. And that's the education we want to give to our, trainees, that you want to always use clinical judgment. It should be higher than any kind of tests or anything else that you are suspecting during these times. You want to look at patient host factors, and you also want to look at local epidemiology with suspected or confirmed severe COVID. And this assessment has to be done very early on, within 1 hour. Ideally with blood cultures being obtained at first. You want to make sure you have all your, you are using all your tools in your toolbox. And early and appropriate empiric therapy can be administered in the ER, which we all do, when we are suspecting a bacterial infection, and the duration of antibiotics should be as short as possible, generally five days or so. So all of these are pearls for antibiotic stewardship during such emergent situations. First of all, if it is a mild to moderate illness, you don't want to use any prophylaxis or empiric therapy. If you are suspecting severe COVID with a bacterial infection, using your clinical judgment, you want to draw blood cultures at first, and you want to use the shortest duration possible. You want to assess your patients every day for de-escalation. De-escalation, like Marco pointed out, is one of the methods for stewardship. So every day you want to see if you can de-escalate. You want to also see if you can switch from IV to oral. What are the other circumstances you want to consider empiric therapy? We saw very high COVID mortality amongst nursing home patients, which were older than 65 years of age, because of immunosenescence. And the fact that they may not mount up an immune response of fever and typical bacterial, pneumonia. So in such patients, you can consider empiric antibiotic therapy. Also in children less than 5 years of age, you could consider empiric therapy. You want to continue your stewardship programs uninterrupted amongst COVID-19 patients. And these are all WHO recommendations. Remember, distinguishing between viral and bacterial co-infections is very important. So you don't want to overuse antibiotics. You have several other signs and symptoms of COVID that we are aware of, including anosmia, which, loss of taste and loss of smell, which are quite typical of COVID-19, and other hallmarks like, persistent cough, diarrhea, abdominal pain can also help. What about C-reactive protein and procalcitonin? They haven't been proven helpful at discriminating patients presenting with COVID-19 or bacterial infections, but they may prove some value in disease severity and predicting prognosis. I don't think it goes without saying how increased antibiotic use has led to the challenge of higher morbidity, mortality. Increasing resistance will be, if this continues the way we are using antibiotics by 2050, it can lead to death of 10 million people and huge costs, $100 trillion to the US. Also, these patients, and I'll show you some of the data, are more likely to get resistant infections like CREs and NDMs. Our NDM rates doubled during the pandemic. Our MDR Pseudomonas rates went up as well. So, one of the main recommendations is that you want to optimize antibiotic use by ensuring appropriate antibiotics are given in the correct dose and correct duration as well, because all of these things can help eventually with decreasing antibiotic resistance. What are the potential threats that could affect stewardship activities during pandemics? One of the threats are that many individuals presenting with mild disease without pneumonia or moderate disease with pneumonia, they receive antibiotics. And we have some data. There was a study conducted in January 2020 in an adult infectious disease unit in China. They found that 71% of patients hospitalized for COVID-19 had received antibiotics, despite a confirmed bacterial co-infection rate of only 1%. So, and we saw what happened with azithromycin. It was widely used with hydroxychloroquine, and it was not really, there was not evidence around its use. I also want to talk a little bit about, Detroit, what happened in Detroit. In general, we know that because of antibiotic resistance, more than 35,000 individuals die annually. And the problem of the pandemic obviously escalated this. But in the background, we were also facing other challenges. We didn't have rapid diagnostic tests for COVID. We didn't have an in-house rapid diagnostic test. We were sending all our samples to the state, which was taking a lot of time. So we weren't actually able to practice stewardship in the beginning. Like Marco pointed out, the importance of rapid diagnostics is so critical, particularly during these pandemics. And we've seen even in the past with the flu pandemic. We need rapid diagnostic tests, and we need them at our disposal in-house, not a send-out test. So what we did was, of course, this is retrospectively, we wanted to understand our antibiotic use during the pandemic, and then we did a sub-analysis within the COVID-19 cohort based on their SARS-CoV-2 status. So this is antimicrobial use in about, as you can see, about overall 6,000 patients in Detroit, Michigan. We divided them into two categories, PUI positive and negative. So PUI are patient under investigations that we are suspecting COVID. And the first column here is non-PUI patients, which means that these patients, we did not suspect COVID in them, and they were about 4,700 patients, and in 1,500 they were PUI negative, and 1,000 of them were PUI positive. And these are basically their demographics, predominantly African American population, and their median age was about 59 to 60 years of age. And then we look at the mortality. I mean, patients who were PUI positive, 34% of them expired. Patients who were So the patients who expired amongst PUI positive were 34%, who were negative were about 10%, and who were non-PUI were 4.7%. To remind you, some of these PUI negative patients may have been actually COVID positive just because, we could have a false negative, 30% false negative COVID test in them. The length of stay of patients that were COVID positive was about median of 9 days compared to 7 days in PUI negative and 6 days in non-PUI patients. And then we looked at top 3 antibiotics prescribed, cefepime, ceftriaxone, and doxycycline. So look at their differences between PUI positive, about 40% received cefepime, 60% ceftriaxone, 60%, and 52% doxycycline, compared to those that were PUI negative. 32% got cefepime, 37 ceftriaxone, and 25 doxycycline, and then way lower numbers for non-PUI patients. So very interesting data. And this was just during the first surge of COVID in 2020. But hold on, I can't. So more interesting than this data is how our antimicrobial prescribing varied during the surge. So this basically shows just antibiotics during March, April, and May 2020. March is when we were seeing our surges. March and April were peak surges. This is just in the PUI positive cohort. So the SARS-CoV-2 positive patients. So antimicrobial prescribing was almost 63% in March, and then it fell down to 42% and 29% in May. So why did this happen? We have a very advanced stewardship program at our tertiary care hospital in Detroit, like Marco beautifully pointed out. But why was our antibiotic use so high? There were several reasons. One of the reasons was we didn't know what we are doing, with these patients, because they were coming in with this such mixed picture, and we had no rapid diagnostic tests in our hospital. So while they were waiting for the COVID test to come back, we were giving them antibiotics as a defense mechanism to try to save them in whichever possible way. They were so sick. Some of them were older. Most of them were older patients. They were dying right and left. And, we didn't think it was antibiotics are going to hurt them in any way. And we were giving antibiotics, lots and lots of antibiotics. So that is where you want to use your clinical acumen, WHO guidelines, divide these patients into mild, moderate, severe, and then determine which patients warrant antibiotics for the shortest period of time. Maximum 5 to 7 days, assessing them for de-escalation every single day, assessing them for switch from IV to oral every single day. So what are the factors, that affect antibiotic use and resistance during the COVID pandemic? About 70% of hospitalized COVID patients receive antibiotics. Often these are empiric broad spectrum. And 16% of hospitalized COVID patients develop a secondary bacterial infection, only 16%, but 70% receive antibiotics. Also, the other important challenge is difficulties in assessing the advice from experts before prescribing antimicrobial agents. There are, remember, the whole system is overwhelmed. I mean, there are so many patients that you can't consult an ID physician on every single patient. And so the stewardship efforts can be undermined because of higher workloads, shifting priorities. The staff is getting sick with COVID as well. So all of these things, can be very, very challenging. And sometimes because of the pandemics, there can be shortages of antibiotics, shortages of important equipment. And certain narrow spectrum antibiotic agents can.
We lost you, Teena. Can't hear you. Kavita, can you hear Teena?
No, Chandra, we just lost her, I think. We can wait. We are trying to find out. She got logged out. Yeah, she got logged out.
Oh,
She has to re-log in, right?
Yes.
okay. So while she's relogging, let's continue the conversation. Let's talk about stewardship during pandemic at your institutions. You saw Teena presenting the data about 70% excess antibiotic use among our COVID patients at our institution. And most of them were for presumed bacterial respiratory infection. And therefore, the antibiotics most commonly used here include azithromycin, ceftriaxone, and doxycycline, and cefepime as well. So these are the 3 or 4 antibiotics we were most commonly using in excess. And then until there were more data that came out showing that bacterial infections, after all, are not that common in the COVID setting. So stewardship stepped in and came out with some criteria as to when we could use empirically antibacterials in the COVID setting and when we could hold back empiric antibacterials. After doing that, our empiric antimicrobial use, I must say, I don't know the numbers, Teena will have the numbers, had decreased with the stewardship stepping in. Do you want to share your experience, Kavita or Murali?
Yeah, Chandra. So in India, the dynamics was slightly different. There was a good lag, fortunately for us. In India, it started in March. By 3rd week of March, there was a national lockdown. So because of that, we all got a good amount of 1 month in the preparation. And by that time, the COVID was ravaging in Spain and the US. And we got to learn a lot from that experience. So we could really understand, and some literature was already available by the time we got COVID. So even in our own institution, we had 3 cases to begin with. Then there was no cases for 1 month because of the lockdown. So we had enough time to understand and try to formulate some guidelines, local guidelines, though there was no national guidelines at then. And the Department of Infectious Diseases was responsible. So we started managing all the cases and leading the team of management. So we were very restrictive about antibiotic use. So though there was even recommendation from the governments about azithromycin and hydroxychloroquine, I am very proud to say that we did not use hydroxychloroquine and almost azithromycin. So yes, it was a very good thing in our institution. The antimicrobial usage was very less. Of course, when as Teena pointed out rightly, when we were overwhelmed, definitely ID was not consulted, and at that time, definitely there was some increase in antibiotic utilization. Of course, when the patients are severe, we do not, at least there will be empiric use of antibiotics until the secondary infections are ruled out. Yes, so we had kind of control, but in the community, I can say that it went quite out of control with respect to azithromycin and also steroids. And you know the consequence, what happened later,
Yes.
mucormycosis, India saw mucormycosis like no other country did. And it's all because of the unrestricted and, rampant use of steroids.
Yeah, absolutely right. I think goes back to ID physicians who are limited in number in India have to take the responsibility of educating general practitioners and primary care physicians how not to use empiric antibiotics, how not to use corticosteroids inappropriately. Otherwise, the price we pay is huge. And I think it is ID physicians' responsibility. Okay, I think Teena is back on the line. Go ahead, Teena. Sorry.
Yes, thank
I'm
you.
glad you're
Thank
back.
you. Sorry about that. So I was talking about infection control challenges that the staff was also facing with lack of PPE and staff shortages that we were also facing. In addition to that, many other things can lead to antibiotic resistance, like increased use of sanitizer or the biocidal agents that are used, likely increased use of antibiotic use in nursing homes, self-medication that you all were talking about. So, these are all consequences of pandemics in general. The parallel pandemic of resistance is going to continue for several years. It's already, we were already in the post-antibiotic era, and now the pandemic is like a fuel to the fire. Many there can be factors that could actually decrease resistance too during pandemics, because remember, there were no surgeries going on during surges. So fewer antibiotic courses for prophylaxis were being given, and fewer emergency and planned, hospital admissions. People were not coming to hospitals for other reasons as well. And obviously we were all masking, and we are all masking, and we are being overtly cautious. All of these things can actually decrease antimicrobial use theoretically. We were, in addition to that, like I said, less transfers from other hospitals were also, like long-term care facilities was also noticed. And patients were mostly cohorted in single units and cared for by same healthcare workers. So all of these factors could actually decrease based on a lot of evidence that we have seen. People should ideally be more aware of differences between viruses and bacteria. There is less respiratory tract infections because of lockdowns, which should also decrease, theoretically decrease antimicrobial use. And in general, less cross-border spread, increased hygienic practices in the community can all actually decrease antimicrobial use. So what are the measures? I think we discussed some of these measures to address antimicrobial resistance. You want to have targeted training for healthcare workers, to increase their competence. You want to give them more, empower them to have a higher clinical acumen, when to de-escalate, when to switch from IV to oral, evaluating the need for medical devices. Does my patient need a line? Does my patient need a Foley catheter? Because all of these are going to cause infections, and we are going to use more antibiotics. Strict infection control measures in the hospital, and making sure during pandemics we are ready for the surges with all the equipment we need, including PPE. So all of these things, how can we continue essential health services and quality care to our patients during pandemics and avoid, shortages of various resources. And, even though US is very, very developed country, but we were not ready. There was our infrastructure in general was broken, particularly in underserved communities like Detroit. We were not at all ready to deal with the magnitude of this pandemic. And in general, addressing gaps in stewardship activities, like the biggest rate limiting factor was our rapid diagnostic tests. I was desperately calling companies to send us some kits so we can test our patients. And the desperation was real because we were sending our samples to the state, like I mentioned, and it took them a week sometimes. At a point of time, I sent 1,000 samples to the state, and they returned all of them back to us because they were out of kits to test. So you can believe this happening here in the US just because our infrastructure was broken. So I would like to just summarize and give one message here, that antibiotics don't work against COVID-19, but stewardship does. Going back to the good old days where medical school, what we've learned in medical school, I did my medical school in India, and one thing that I learned there was your clinical acumen. We didn't have any rapid diagnostic tests to test our patients, but we did have that clinical knowledge to understand if this is a viral infection or not. And going back to the basics is going to help us during this time, and remembering those principles of stewardship. I would like to stop here. And again, I want to really thank you, Dr. Chandra and Dr. Kavita, for having me. It's a huge honor.
Great. Thanks, Teena. Thank you so much for the nice overview. It's a very pertinent, timely topic, any country, anywhere around. I don't see any question and answer in the Q&A area. We'll open it up. Kavita, do you have any comments or questions for Teena at this point on this particular area, or your own experiences at your center and the neighboring centers?
There is a question, Chandra, in the chat box.
Okay.
I just
Go
called
ahead.
written. We found a good bit of bacterial infections in COVID patients who received baricitinib or tocilizumab. Any specific recommendation he wants to know?
Go ahead, Teena. Go ahead.
Yeah, we haven't looked at that data yet with bacterial co-infections in these patients, who are specifically on TOSI or Bari. But yes, I can tell you that a lot of these patients have severe COVID, and they have been in the hospital for a long period of time. And all of those factors, and they have multiple devices, ventilators and lines and Foley catheters, all of which are risk factors for multi-drug resistant infections. So these are the patients that warrant empiric antibiotic therapy. And of course, these monoclonals can also, affect their immunity further. The organisms that we have isolated in these patients, which is the next question, is predominantly your CREs, multi-drug resistant Acinetobacter and Pseudomonas, which are very, very common in these patients. In fact, we did present some of this data at ID Week this year. And, based on all these risk factors, you want to use broad spectrum antibiotics on them because they have the typical risk factors for multi-drug resistant organisms. So we have seen that here as well, and have had to use these broad spectrum antibiotics because these MDROs will further add on to their morbidity and mortality.
I just want to add to what Teena just mentioned. Remember, these are very potent immunomodulating drugs. And when these patients have super infections, it is generally recommended not to use these drugs in COVID patients who have super infections with bacterial organisms or fungal organisms, because the outcome from these infections, as they're exposed to anti-IL-6 and other such agents, is usually pretty bad. So the general recommendation would be not to use immunomodulators in patients who have super infections with COVID infection. Please remember that. And organisms, as you would expect, are usually hospital organisms because they've been around for a while in the hospital. Okay, good. That's a very important point to emphasize. Kavita, anything else you want to bring up?
There is another question. How did you deal with difficulty in hand hygiene with universal gloving in COVID ICU?
Yeah, that's a great question. So, we in the COVID ICU, we didn't do universal gloving like all the times. We used gloves, gowns, and masks when we entered patient rooms. Before you do that, you want to wash your hands. So the first step of donning PPE for COVID is you wash your hands. So you wash your hands and then you glove. Is the sequence of the way you don your PPE. So we, in between patients, we remove the gloves, again wash our hands, and then go on to the next patient. So that is obviously takes a lot of time, but you know, every time when Ebola happened, we did a lot of education among our staff around COVID precaution, around PPE donning and doffing. And I think this has to go on all the time. The training, the in-servicing of staff around donning and doffing has to go on all the time in between pandemics as well. So they have the habit of doing it. So that's what we do here. We don't do universal gloving all the time.
Kavita, how freely available was the PPE in various institutes? I'm sure there was a severe shortage and you had to improvise. You want to comment on that?
As I said, we got a good amount of time. So at least in this part, we did not have shortage of PPEs. And there was a lot of encouragement for the local make. So a lot of encouragement and small scale industry kind of people, they took up the job of manufacturing PPEs. So I really should say that we didn't have shortage. Of course, there was a big threat of shortage of masks. We were worried, looking at other areas. Surely we were worried, but we did not have shortage. I can say that we did not have shortage of masks. We did not have shortage of PPEs. And I'm very happy to say that we did not have healthcare worker mortality here. So in the entire district of Udupi, we did not have any healthcare worker mortality in COVID-19. So I think it's all because of the PPE. So the availability of PPE, that made a lot of difference.
Very good, very good. Well, there is somebody named Monica. Teena, I don't know if you can read the chat box.
Yes,
There's a question for you. Go ahead.
Yeah, so the question is if there is a hand rub over the gloved hands, you know, if you can recommend that. So when there is no, I would not recommend hand rubbing over the gloved hands. There is no evidence around it that it works, and you know, in fact, it may do more harm than working. So I would not recommend hand rubs over the gloved hands. I would rather wash my hands, glove them, and change the gloves in between seeing patients. That's what is a recommended practice.
Okay. So now I don't see any other questions. So let's keep chatting. Now we have influenza here, Kavita. We have what they call the twindemic, right, Teena? It's several cases have been reported. It's the influenza season for us. And this is COVID on top of influenza. Just in this area, there have been several hundred cases already reported. So we don't know who has COVID, who has influenza, who has both, or who has RSV. So it's become a challenge. So our testing modalities have also changed to include all common pathogens. Teena, do you want to comment on this?
Sure. So like Dr. Chandra pointed out, we have the 4-plex rapid diagnostic PCR that we are using, where we are testing for influenza A, B, RSV, as well as COVID. You know, we have seen a huge outbreak of influenza A, H3N2 in one of our universities here. We had 500 cases of influenza A, and you know, just community transmission, and also the fact that people have stopped masking. You know, there was a time last year when we did not see a single case of influenza, and our strep infections went down, our RSV infections went down, but all of that reversed this year because people are just not masking. You know, of course, there is vaccination as well, but we still have people who are unvaccinated against influenza and against COVID. So we are facing this twindemic, and that's why it is their symptoms are, it's blurry, everything is blurry, so we have to test for everything. we also saw a huge surge of RSV in adult patients, not only in children, but also in adults this year because of the fact that other viruses are now have gone up. So that is a concern as well. And I'm sure other countries are also going to see a very similar trend moving forward as the weather is changing.
In India, I don't think so. Everyone tests for other influenzas. So that is one we do not see because we do not test. In this hospital, yes, the testing for influenza this year was much less because of the COVID. Everyone was testing for COVID and the testing for influenza went down. When we have tested, we have found that H3N2 was more than H1N1. So there was a change with respect to influenza. It was H3N2, but I'm sure we are seeing 100th of what is probably present. And but
what is
making a difference? Probably masking is making a difference. The vaccination is not great. Like the uptake of vaccination is not to a significant degree. I can say that.
Is how
Influenza,
good
right?
is? Sorry, go ahead, Teena.
Sorry, I was going to ask you if you give influenza vaccination in India, because that is a big factor as well in India. That I don't see a lot of uptake of influenza vaccination there.
Yeah, very few people practice adult vaccination, adult immunization. It's a cost consideration most of the times. Yeah, so in the very high risk individuals, definitely it's advised, but the uptake is much less. I can say that.
Hopefully, COVID increases the awareness of importance of adult vaccination in India. India is the world's leader in vaccine production. They are the #1 vaccine producers, and yet the adults are deprived of all adult vaccines. This again, I think, is a job for the infectious disease physicians to be aware of the lack of adult vaccination rates or the poor adult vaccination rates, and hopefully COVID vaccine may serve as an impetus to improve vaccination rates against other infections as well.
Yes, that will definitely make sense to the public.
Yeah, I think Ram Subramaniam has an adult immunization clinic, right, in Madras. And like that, there should be several adult immunizations, at least in large university hospitals.
Yes, we do have, but in general, the cost constraints, out-of-pocket expenditure, that is a factor because pneumococcal vaccines are expensive.
Very good. Well, it's 9:15. Let's see. Somebody has said vaccine is luxury in India. Of course, yeah, it is a luxury. Yeah, but when you can use cefepime and ceftriaxone and piperacillin tazobactam, I think vaccine by Reddy Labs is a few cents. Please remember that. It's all a matter of priority. Priority. We don't really fully realize the value of vaccines. We realize it in children, but we do not realize it in the adult population. And pneumococcus continues to be the captain of death in the elderly. Okay, any final thoughts, Teena, and then Kavita, and then we'll close? Teena?
I think my final thoughts are basically the fact that, community and not only hospital-acquired stewardship is important, but also community stewardship, antibiotic stewardship in the community is extremely important, particularly in underserved areas. And we are struggling with it. And I'm sure in India, it's in its infancy. And that is something I would urge you to think about, moving forward, to have a broader sort of concept of stewardship, because I know that in the community, it is so easy to buy antibiotics from the pharmacy and just pop it like a pill. So that is my final message. And again, thank you so much for having me.
Kavita, any closing comments?
We would like to play a video before I give my final comments.
Say that again, I'm sorry.
I would like to play a video thanking our
Okay.
sponsors of the event. And we have an ID program and DM infectious diseases in our department. We would like eligible candidates to apply through NEET, a common entrance examination, super specialty entrance examination in India for DM infectious diseases, and eligible candidates can join our program. So I wanted to show a video about our facility, and also I represent Clinical Infectious Disease Society of India, and I would like people who are interested in India to become members of Clinical Infectious Disease Society. We have online registrations, online membership is possible.
Thank you for the excellent work you guys are doing, and wish you all the very best.
So it was about our sponsors who have helped in putting up this program for a week. Tomorrow we have competitions for students about a debate on antimicrobial stewardship, slogan writing competition, and similar other competition amongst students to be involved with the antimicrobial week. And also we are involved with Going Blue campaign to raise awareness about antimicrobial stewardship. And our institution campus will be lit up in blue on 24th of November. As individuals, we are dressing in blue whenever and whoever is interested in solidarity about for antimicrobial resistance. And I'm very thankful to faculty from Wayne State University for joining and giving such wonderful lectures. And our program and viewers are enriched because of their experience. And this is not the last time, definitely I can say that. I'm very interested to have continuing collaboration and learning experience in future. I'm very thankful to all three speakers and Dr. Chandra for coordinating with all of them. Thank you very much. And I also thank the participants who have been viewing our program online. Thank you very much, and continue to attend our programs the subsequent days in this coming week. At the end, I would request the panelists to stay back for a photograph. If you can switch on the videos, all of you. All the panelists for the photograph, please.
I don't know if Sanjay is in or not. Is Sanjay still there?
I'm very glad, and we'll reach out to you in future. Marco, Teena, Sanjay, and Chandra. So this is going to be
anytime. You guys are doing. I'm very glad what Manipal Medical School is doing in that part of India. Infection is always neglected and ignored. You are pioneers in this area, promoting the awareness of infection and educating younger physicians, motivated and becoming infectious disease physicians, recognizing there is not that much money in the field, nevertheless out of interest. So you guys should be applauded for what you guys are doing. And whatever we can do from Wayne State, we'll be happy to do it, to promote this. So is the picture taken or what's going on?
Yes, taken. And I welcome all of you to India. Teena, you're welcome. And Marco, I don't know if you have visited India ever.
Marco, you should go with me.
But I would love to go.
And Sanjay.
The next meeting would be in Manipal live.
Yes.
Thank you so much,
As long
Kavita,
as travel
for the invite.
restrictions are out, I'm okay.
Okay, guys, we'll see you later. Thanks
Thank
for
you.
putting it all together. Thank you.
Thank you.
Bye-bye.
Bye-bye. Bye.
Bye.
Thank you. Bye.
Someone is asking for email.